Now, the next speaker is, well, the next three speakers are very talented speaker from Baird Academy, but the next one is a special one because not only she works with me in Baird Academy, she's part of the scientific committee, but I'm also blessed that she's part of the clinical team. Together, we work, me and her, in Leeds, and Victoria moved to the United Kingdom, as she will tell you, 3 years ago, and since then joined the implant team, and she's been on a fantastic steep learning curve. And as you will see from her lecture, I'm going to tell you, you're going to learn a lot. It's a great pleasure to see Victoria lecturing again for Baird Academy. Victoria lectures internationally and nationally, and it's amazing to have you with us, Victoria. Are you there?
I'm here.
Excellent.
Thank you so much, Hassan.
Stop sharing the screen so you could share with us your lecture, which I'm so looking forward to it.
Thank you, Hassan. Thank you so much for all your kind words. It really, I can't even begin to express what Baird means to me and how Baird changed my life, and how I started and where I am right now.
Excellent. All right, all yours.
Just 1 second, sorry.
Well, in the meanwhile, I would like to give some shout outs. We've got audience from all around the world. We've got Saudi Arabia, Medina Munawwara, we've got Texas, we've got UK, Iraq, Tunisia, Croatia, Macedonia, Jordan, Doha. And it's amazing, you know, Turkey. It's amazing having people from all around the globe, and obviously Solange, Cyprus, all around the globe with us, watching this amazing symposium by our young members. This is something designed by our young members, organized by our young members, presented by our young members, and that's making us all proud of our Baird graduates. Victoria, without any further delay, the mic is yours.
Thank you, Hassan. I wanted to start by also acknowledging all the hard work that the Baird team has been doing behind the scenes. Thank you, Dr. Hassan. Thank you, Dr. Tamer. Thank you, Solange, and all the participants that came into our panel today so far. I'm really looking forward to, I was so surprised to share the platform with you, but there you go, here I am. So for those of you who are now tuning in, my name is Victoria. I work in Leeds at the moment, but I was born and raised in the beautiful country of Bulgaria. Sorry, just give me 1 second. For some reason, my presentation is not moving.
Victoria, try to use the arrow rather than the mouse.
Yeah, I'm trying, but it's just giving me an error.
Okay, try the mouse then. One of them will work.
Okay, there you go. So I was born and raised in the beautiful country of Bulgaria, and my city is called Plovdiv. For those of you who are looking into beautiful destinations to book in after the COVID-19, you can definitely look into Plovdiv. It's been announced to be the European Capital of Culture of 2019, and it's also the 6th oldest city in the world. It has cultures from the Romans to Greeks to current times, so it's definitely worth visiting. My early years I spent in the Medical University of Sofia. I graduated from the Faculty of Dental Medicine. This is my group. We share fun moments together. Every time I go back to this slides, I think how little did we know back then about dentistry or about medicine, and how much things have changed so far. I developed a great interest into surgery and into prosthodontics. So I was looking to find a pathway for myself. And little did I know, the path was straight from an airplane distance going directly to Leeds. So because I met this amazing team in Bird, I took a flight and I ended up in Leeds. This is my team. This is our group. I put this slide to show you where my journey started. But if I have to start talking about what the British Academy of Implant Restorative Dentistry done for me, 20 minutes wouldn't be enough. An hour wouldn't be enough. A day wouldn't be enough. I have been so lucky to meet all these people who influenced me, who infected me with their passion, show me the way for the evidence-based dentistry. Hassan, thank you so much. Dr. Ziad, Professor Marco Esposito, Dr. Roberetti, all of you, Dominiki, it was great working with you and meeting you. Dr. Iman mentioned earlier in one of his presentations that Bird also helps you bring connections. So this happened with me. Within the last 3 years, I've been connected with the ITI. I've participated within the Young ITI lectures in London, in Dublin. I've been part of the ILID as well, which is a great honor, thanks to Dr. Walid as well. So Bird can help you grow, and it helped me grow a lot, and it helped me break through my shell and be here today to share with you the knowledge that I have. But most of all the things that I've told you, I'm blessed to be working with an amazing team. As Hassan said, this is our team in our private practice where we do what we love, or we preach what we do. So you can see this is me, Dr. Magera, and Laura, Ms. Costello, who is our implant coordinator. Without the three of us, I cannot get my daily dose of happiness. So without further ado, I want to talk to you today about immediate implant placement. And I chose this topic because 21st century, we all know that our patients, they want more. They want everything to be done quicker, to be done at the perfect level, and to be cheaper. And immediate implant placement has been known to have a peak or a rise of appreciation. So my presentation today is a case. I'm going to show you an immediate implant placement that is in the aesthetic region, where we used a biological driven approach and we managed to achieve an acceptable result. So this is a lady, an elderly lady in her late 70s. She came into our practice. She didn't have high aesthetic expectations. And as you can see in the lower picture, she doesn't have high smile line as well. So her main concern was she wanted everything to be done quicker, to have less surgical time, to minimize the surgical procedures, and to minimize the surgical healing. So we discussed with her the options of immediate placement, and this is the option that she requested. She had upper left central, which was failing post-crown with vertical crack, and upper right canine, which is also a failing post-crown. At the initial consultation, we took these two x-rays where you can see and where we can assess that there is no signs of acute infection. We also checked her soft tissues, and we can see that we have thick biotype in her case. But the one thing that we were missing was the CBCT findings. So we asked our patient to have a CBCT, and we assessed what we find. So you can clearly see here at the upper right canine, we have about 1.5 millimeter thickness of the labial plate. And at the upper left, we have almost less than a millimeter. Why do we look at those things? Because there are 3 points to look at when we think about immediate implant placement. We have to make sure that we don't have signs of acute infection. We have to make sure that we have thick biotype, and we have to make sure that we have sufficient amount of bone. Hence, we're taking the CBCT and we're assessing the labial plate. As you can see in these images, the labial plate and the canine region, we can clearly see it. However, the one on the central incisor is not completely visible. Well, that's not unnatural because this study shows that the CBCT findings, they're not always completely accurate. And in most cases, we can have a thin labial plate, which is less than 1 millimeter, but that wouldn't show within the images of the scan. But that doesn't mean that it's not there. Okay, and one more thing that we noticed in the scan is that the angulation of the roots, both roots are angulated into type 1 according to Joseph Kahn's classification, which means we have the root is touching the labial surface, but there is sufficient enough of bone in the palatal surface to have an immediate placement. And already in the scan here, we can show that the root is inclinated, so we might be expecting a perforation. As we all know, one of our favorite saying, when the Dr. Magera mentions very often, is that bone sets the tone, but soft tissue is the issue. So one of the great considerations is to make sure that we have sufficient amount of soft tissue before we decide how we're going to design our flap. So we take a probe, we do bone sounding, we see that both areas are favorable. We remove the root very gently, and it came out in one piece. And here we've done our initial assessment. We were hoping to make everything for this lady in one go. So we were thinking, that's great, let's have the immediate placement, and maybe if possible, we can do it flapless. However, once we started cleaning the granulation tissue, we use these granulation tissue bearers, which you can find in Swallow. They're really good. They help clean the surface and reduce the blood around the area. So after we cleaned the granulation tissue, we did bone sounding again, and you can see on the image on your right that clearly there is a perforation around the site. Therefore, we decided to make a minimally invasive flap. So we did a semilunar flap only around the apical third, where directly we managed to clean the fenestration, clean the granulation tissue. And from here, we could measure and we could see that the labial plate is about 1.3 millimeter. Okay, we move to our implant placement. We spend a lot of time in the beginning during this consultation visits to take study models, to prepare a surgical guide, and to make sure that we have an accurate wax up from which we can prefabricate a surgical guide. The surgical guide helps us place the implant in the correct prosthetic position, which in this case is in the cingulum region. And if you can see here around the socket, it's palatal towards, as palatal as possible within the socket. Once we place our implant, we fill in the gap. We fill in the labial gap with some autogenous bone. You can either use autogenous bone, or in this case, we used allograft. Another use of the allograft is to cover the exposed threads of the implant as well. Okay, and then we sutured everything together. We didn't manage to reach good high torque stability because it was a very big socket. So the implant had about 15 or even less torque in this situation. So we decided to go to submerged placement. However, we still used at least 2 millimeter healing abutment so we can achieve the tinting effect that we really like, so that can support the soft tissue. To achieve a perfect closure, we used the soft tissue graft that we harvested from the tuberosity. We de-epithelialized the corners of the soft tissue graft and the internal part of the socket, so we can have a good healing connective tissue to connective tissue. Okay, after we finished with the canine, we moved at the same day on the same surgery towards the central incisor. We did bone sounding again. Already from our CBCT, we knew that we have very thin labial plate. And once we talk about flap design, our practice follows the rules of biology. So we don't make flap design just by chance, and we treat every different case differently. And on a different topic, on a different day, we can talk about the decision-making trees and the specific questions that we ask ourselves. Why should we raise a flap or we shouldn't raise the flap? One of these questions is if we're gonna have to do GBR. In this case, we were planning to do GBR, so we extended our flap 1 unit more. However, to preserve the blood supply of the adjacent teeth papillae, we used the golf club technique. We used the 15C and we gently elevated the soft tissue together. One of the other advantages of elevating a flap is that you will manage also to remove the root without putting too much pressure on the labial bone. Yes, elevating the flap might mean more bone resorption. However, once we remove the tooth gently, we preserve the labial plate. We're also able to graft inside the socket and outside the socket as well. This is the image after we remove the root. There is labial plate. We managed to preserve it. We managed not to damage it, but it's still very little. It's less than 1 millimeter. We follow the guidelines and the rules of the ITI of the correct implant position in the central incisor. This is within the prosthetic envelope. And as previously mentioned, it is palatal, as palatal as possible within the socket. So what we want is to have a buccal gap, not palatal gap. And here you can see clearly the implant is touching the palatal surface. We graft the labial gap with allograft, and we do the steps of the GBR. We start first by stabilizing our membrane. We use stabilization pins, and we make sure that the mesial part is very solid before we start putting the layers of our graft. We're using the layering technique concept developed by Dr. Magera, which stands for using the first layer of autogenous or allograft to cover the exposed threads, which we're expecting to have quicker remodeling. And then we're using a second layer of xenograft, pure xenograft, or we use xenograft mixed with allograft. And just so we can have scaffold that will help the ridge remodel and preserve that good ridge contour. We flick the membrane towards the opposite side and we stabilize it with another pin. The difference between the canine placement and the central incisor placement is that we managed in the central incisor to achieve good torque. So we used a healing abutment and we left it exposed, which is transmucosal placement. When we were done, we sutured everything with a good closure. We used Prolene sutures and Vicryl sutures. The patient was left with her temporary ruchette for 2 weeks. Then we removed the sutures and then we left the bone to do its magic. 12 weeks later, this is the situation we have. We have good soft maturation. The implant with the transmucosal placement has good sufficient healing around. And we moved to our second stage. The second stage was our exposure stage, but I put this image here just to show you how we preserving the labial plate on one side helped us, the soft tissue graft helped the soft tissue mature, the soft tissue that we gathered from the tuberosity. And on the other side where we did the GBR, it was the same volume that we wanted to achieve. On the second stage, we did exposure. We did trophine because the soft tissue that we used from the tuberosity matured really well, so we had extra keratinized mucosa. And we've done the chair-side temporary crowns for her. So here you can see we isolated the teeth and we put 2 titanium temporary abutments. We use the patient's guide or any temporary crowns that you have at the moment to prepare her chair-side temporary. So the story goes, we have an implant placement and we have beautiful soft tissue, but we want to achieve perfect profile. How do we achieve the perfect profile and why do we use temporization? We need to focus on back to biology again. And why? Because we talk about this transitional zone. When we talk about transitional zone, we need to talk about an equal gingival margins. We need to talk about making similar zenith between both incisors. We want the emergence profile to be healthy and hygienic. We want to have perfect gingival seal. We want to have good labial convexity that will mimic the natural tooth. And we want to have good papillary support. We spend good amount of time of during the temporization. This is a favorite topic of mine, the prosthetic soft tissue sculpturing, which is where using the temporary crown, we manage to bulk the soft tissue without doing any excess surgery. At the different day with more time, we can talk about all the features that a temporary crown should have, so you can achieve this in a very easy way. Here we adjust the distal contour so we can leave more space for the papilla to grow. And gradually, between 4 to 6 weeks and in between the appointments, we add some composite on our temporary crown so we can make sure that we achieve beautiful hygienic profile. Okay, so from a circular, if you remember the first slide, from a circular, we reached to an ovate shape for the canine and triangular shape for the central incisor. Once we achieve that beautiful profile, we want to mimic everything that we have in the patient's mouth and send all that to our lab technician. We do that by customizing the impression or customizing the impression pickups. Here, we take impression of the crown with the index. We use impression pickups that we customize with flowable composite. And this is where, once you remove the temporary crown and you put back the impression pickups, that supports the profile. And all that within an open tray technique will stay again in the impression. And our lab will have a reference point to where to mimic perfect profile the same way as it is in the patient's mouth. We finish with two screw retained crowns on CAD/CAM abutments. And this is to show you where we started from the canine. If you can see the difference, the beginning, we had even less soft tissue than where we ended up. And this is simply because we managed to preserve the labial plate and we used a soft tissue graft to bulk the keratinized mucosa. Patient was very happy. We managed to save her surgical time. We preserved biology. And once we fit the crowns, we use a Blue M gel. This is self-oxygenating gel. Okay, and this is her final result for her central incisor. And here you can see the beautiful convexity we achieved with our grafting material. So it's safe to say, this is our immediate placement, and this is our implant placement in the post-op X-ray. You can see there is good labial plate on both implants, so we are happy, they're well protected. So it's safe to say that we need to put some reflections, and I learned a lot just through this case. One of the most important things in immediate implant placement is the patient's selection. So there are specific criteria you need to know, and this is a very good study that follows the factors that influence the immediate placement. So if you have an anterior tooth, or if you have a smaller buccal gap on the distance, or if you have thin phenobiotype. So there is also, if you're thinking about phenotype as a soft tissue, there's also a special classification where it classifies thin bone and thick bone phenotype as well. Another similar study agreed with the previous study and added extra risk factors. The one difference that they added here is that there is also the facial malposition of the implant. And not only that, that tells us that it's technique sensitive. So if you do place the implant in the wrong position, then you are at higher risk of not having a successful placement. So why is it technique sensitive? Because the horizontal bone loss depends a lot on the thickness of the crest. So preserving the labial plate, making sure you have very minimally invasive extraction is a must. And placing your implant as palatal as possible. So increasing the labial gap, that will also reduce the risk. However, another study tells us that if we do place the implant buccally, then we increase the risk of over 70% to have a mid-labial and mid-facial recession. So my evidence, there is an evidence-based recommendation. If you want to do immediate implant placement, you have to really assess the risk, find the right patient selection, and have good training to have specific technique. So what this study will tell us what to do to reduce the risk of mucosal recession. So if you don't want to have labial recession, then you want to have intact labial plate, you can do a simultaneous soft tissue graft, as we've done. You could do ridge contour, and in some cases, whenever it's possible, you can do a flapless surgery. One of my colleagues, Lev, is going to talk about the flapless surgery in a bit, so please stay tuned with him. And my last but not least, I think most important take-home message comes from Professor Marco Esposito and his team, that they published a study in 2010 in eJoy that says the early placement is still considered the safer option comparing to the immediate implant placement. Thank you so much for tuning in with me. I hope this presentation will help you have some tips and hints into your implant practice in the future.
Thank you, Victoria, for a very nice presentation, good quality work, good quality slides, and straight to the point, evidence-based message. So thank you very much.